All right, now I'm the host. Oh, for God's sakes.
Hey, all right, let's go.
Okay, I found a little funny on Instagram. All right, this is weird. It's double. Y'all see the funny? I thought this was cute. Haha. Okay, no response. Moving on. All right, 8:35. Let's do this. Acute kidney injury. Remember I mentioned last week. Okay, you guys start up your recordings. Start up your recordings. Remember I mentioned last week that acute kidney injury and chronic kidney disease are parallel. Okay? They are two different things. Acute kidney injury, the patient will recover from. Chronic kidney disease is a progression towards one of three things: dialysis, kidney transplant, or death. So, patients, once they're in chronic kidney disease, cannot recover. Patients in acute kidney injury can recover, but they can also go into chronic kidney disease if their problems are not dealt with. So, acute kidney injury is a rapid decline in kidney function. Make sure you mark this while you're studying about the causes. Pre-renal is a reduction in blood flow. Intrarenal is a result of direct glomerular damage, direct insult damage to the kidney themselves, the functional physiological components of the kidney. And then post-renal is an obstruction of urine outflow that causes hydronephrosis, which can also lead to sepsis and kidney failure, acute kidney injury. So your diagnostics, urinalysis, kidney ultrasound, kidney scan, CAT scan, MRI, and a biopsy. The prognosis is the patient's overall health. It's dependent on that, whether they have comorbidities, the severity of the kidney failure, and any complications that arise. All right, so this is the patho. Hypovolemia and decreased kidney blood flow leads to vasoconstriction. You have ischemia, stuff starts dying. Ischemia to cell death. Think of myocardial infarction with cell death of the myocardium. Think of diabetes with little to no blood flow to the periphery, and then the patients wind up having amputations. Same thing with within the kidneys. Edema occurs, that inflammatory process kicks in. Intratubular pressure creates the leakiness in the glomeruli, and then that's when you start seeing protein spilling into the urine. Okay, so the next two terms, these are nice to know. You don't need to memorize them. The Reifel classification is a marker on what is happening with the kidneys. What is the risk? What's the injury? What kind of failure? Kidney function loss down to end-stage kidney disease. And KDOQI it's the acronym for the Clinical Practice Guidelines for Caring for Patients in Kidney Disease. These two terms are nice to know. You can, if you go into kidney failure as part of your nursing practice, you can become familiar with these through the National Kidney Foundation. All right, so feel free to take a picture. This is a supplemental slide to help you understand for those visual learners. Pre-renal, number one, you can see the number one over here. There's blockage in the renal artery right here. Any types of interruption of blood flow is a pre-renal cause. 2, intrarenal is direct damage to the glomeruli through inflammation, toxins, etc. And then post-renal, think your obstruction, ureteral stone, bladder stones, prostate, BPH in elderly men, etc. Okay. So here are some examples of acute causes. Whoops, that stupid mouse. Here are some examples, some tangible examples of acute kidney injury as you're studying. I don't know, I can't recall, I don't have a copy of the outline, but if you don't have this in the outline, go ahead and take a picture of this. Pre-renal causes: hypovolemia, shock, think peripheral vasodilation, sepsis, PE, any type of heart failure, decreased cardiac that decreases cardiac output, cardiac tamponade, some type of systemic vascular obstruction, liver failure, and even anaphylaxis. That will cause issues as well. Okay, your intrarenal are your drugs, nephrotoxins, nephritis, renal vessel occlusion stenosis, which leads to a thrombosis, acute glomerulonephritis, acute tubular necrosis, prolonged ischemia, autoimmune diseases. What are some examples of autoimmune diseases?
Lupus.
Yep, what else?
Rheumatoid arthritis.
Yes, rheumatoid arthritis, very good. What else?
Sickle cell.
What's that?
How about diabetes?
Diabetes, yes, can be autoimmune. I think, aren't they classifying type 1 diabetes as an autoimmune? I don't know.
Hashimoto's.
Hashimoto's. How about sarcoidosis? Any type of autoimmune disease can lead to kidney dysfunction. Crystal formation in the tubules, myoglobin, hemoglobin disorders. We're going to talk about that, especially in rhabdomyolysis. We'll talk about that. That seems to be somewhat common these days that you'll see on med-surg and ICU. Hypertension and ischemia, anything that hits the kidneys directly. And then post-renal, BPH, blocked catheters or ureters, any type of calculi, trauma. If you have a patient come in who has a crush injury to the lower abdomen with a fractured pelvis, think of all the structures and everything that the pelvis protects. Your GYN organs, kidneys. It may have a ruptured ureter. Another thing is postoperative complications. We see that sometimes in GYN surgery. A surgeon can nick the ureter because they're going in and taking a tumor out. So what they do is they inject a blue dye, indigo carmine or methylene blue, and then as the patient urinates, if they have a bunch of blue dye accumulate in the abdomen, they know they cut the ureter. So that might be a post-op thing. If you see blue dye in the urine, that indicates that they're assessing for proper outflow from the kidneys. Neurogenic bladder, genitourinary and GYN tumors can cause obstructions, cervical cancer, anything that blocks outflow. So all of these together, the result is a nephrotoxic insult with acute tubular necrosis, and the acronym for that is ATN. All of these cause a nephrotoxic insult with acute tubular necrosis. So if you see that in the notes, that's what that means. All right? Any questions about the causes? Comments? All right, another list. I like my lists. These are your nephrotoxic drugs. Yes, acetaminophen because of liver failure, but it could also be problematic to the kidneys. Even more so problematic is ibuprofen. We'll talk about that in a minute. Anesthetics can be nephrotoxic, antifungals, antivirals, your aminoglycosides, your gentamicin. That's, you see that a lot in pediatrics treatments. Captopril is a IV push ACE inhibitor. The brand name, and forgive me if I butcher this, is enalapril, ENALAPRIL. You don't really see this used that much, but it is a medication that's out there. Your chemotherapeutic agents, patients undergoing chemo, it's killing the cancer cells, and it's also killing all the other cells. That's why you lose your hair, you lose your eyebrows, just think, along those lines. It's also, impacting the kidneys. Cyclosporin is another medication. Heavy metals. Can you guys think of a heavy metal that's endemic to the New Orleans area?
Lead paint in water.
Lead paint in the water and in the ground, in the ground. And so what happens with that is young children or adults who have PICO, which is uncontrolled eating of non-nutritionist substances, you see that in pregnant women. Kids playing in the dirt, and you have all these old lead-based paints that were used many years ago. They don't put lead in paints anymore, but New Orleans housing stock is, a couple centuries old, a lot of it, and so there's a lot of lead paint in the ground, and especially with all the destruction post Katrina, it has magnified that issue. So what can be done? What's the problem with lead poisoning in children?
It's a neurotoxin.
It's a neurotoxin, and it affects cognition, and so it blunts the processing of information and whatnot in the brain. So how do you get rid of that if a patient comes in with lead poisoning? How is that eliminated? Does anybody know? The patient is administered substances that binds with the lead so that they can eliminate it. And there's a term for these substances. Does anybody know?
Chelation?
Yes, it's chelation is the process. They're chelating agents. CHELATING, chelation. And so for those of you going to work at Children's or in a pediatric environment, in the ED or in the clinics, you may see this. Okay, so on the next column, there are a few drugs that are weight-based. They need their levels monitored. And the big one at the top in bold is IV contrast dye. In addition to them being iodine-based, what is a problem with an iodine-based substance in patients?
They can have an allergy.
Yes. Allergies to what specifically?
Seafood, iodine.
Yes, that's correct. There's a cross allergy with seafood, especially shellfish, and iodine. So a person who is allergic to seafood, shellfish, or iodine cannot get IV contrast dye that is iodine based. The other thing, it's weight dependent. So I think I mentioned this last week. For those of you who go into any type of radiology practice or radiology environment, administering IV contrast dye, y'all need to do calculations based on the patient's weight and not administer more than what's the dosage required, because then the patient will go into kidney failure. Lithium, what is lithium for?
Bipolar disorder.
Bipolar disorders, very good. This is also nephrotoxic. And so lithium, excuse me, lithium has fallen out of favor because there is a therapeutic range, a very narrow therapeutic range for administering lithium. Does anybody know that range? The range is 0.6 to 1.2 for lithium levels. So once in a blue moon, you'll see a patient on lithium, but it's not abundantly used anymore like it was maybe 20, 30 years ago. Metformin, it's a very common drug with type 2 diabetics. This medication, what is the problem with giving metformin? What is the precaution with metformin?
It has to be stopped before IV contrast for 3 days.
Yep, 2 to 3 days before any type of procedure, metformin needs to be held. So bear that in mind if you are giving teaching instructions and whatnot to your patient if they have to return for a procedure. Methotrexate, that is a common drug. My brother has psoriatic arthritis, and he, with all the prescription drugs, and they got all these really cool things, Enbrel and all of them out there, but they cost a fortune. So methotrexate is the drug of choice because it's cheap and it helps him manage his psoriatic arthritis. But the problem is it's very nephrotoxic. So it also triggers anemia. So he has to go in pretty frequently to get his kidney function test done. He gets a BMP, they check the GFR, creatinine, BUN. So it's a good drug, but it can be pretty toxic. Your NSAIDs, especially ibuprofen, is nephrotoxic. Patients who are on NSAIDs, any of those in the list, naproxen, celecoxib, meloxicam, ketorolac, these meds should really only be taken over a short duration. Not as short as like antiemetics like promethazine, but these NSAIDs should not be taken religiously because they will lead to kidney failure. We had an elderly family friend of one of my aunts who was taking, 24 pills of ibuprofen a day. That's unrealistic. That's unheard of. She wound up going into kidney failure and was on dialysis and then died 6 months later. There's no reason to take these NSAIDs in such volumes. The problem has to be identified with why this person is taking all these NSAIDs, and it needs to be fixed. So, maybe there's dietary things, maybe they can change their diet to reduce inflammation, I don't know, but taking NSAIDs long term is never good. Pesticides and fungicides, these are also nephrotoxic. And the big boy at the bottom, vancomycin. Yep, we had an incident this week with vancomycin. What's the peak and trough for vancomycin? What's the trough? What's the range? Put it that way.
10 to 20.
Correct, 10 to 20. And make sure you check your trough. They don't check the peak anymore, they check the trough. So when do you think they're going to draw that level for trough? Before or after they give the vanc?
Before, 30 minutes before?
Yes, correct. So we had a patient this week, and this patient was in the hospital a week, and on the 18th, which was this past Sunday, was the last time they had a trough. And it was good. It was subtherapeutic. It was 9.2. So this patient received 7 doses of vancomycin, and we were getting ready to give the 8th dose on yesterday morning, and I spoke to my student. I said, "What's the trough?" And she's like, "Well, he didn't have one." And she said, "Isn't that a problem?" So kudos to the student. She picked up on that right away. And so we followed up, we counted the doses back because that's a issue in EPIC. When you're looking at your MAR, plenty times when they start vancomycin treatment, they'll start it at a truckload, like a loading dose, 1,500 milligrams. And then they'll do a couple of doses of that. Then they'll drop it down to 1,250. Then they'll drop it down to 1,000. But the problem is, in EPIC specifically, when they change those dosings, the med falls off. And you can't always go back and look at the old dose to count how many the patient received. So we went into the orders and the discontinued orders, which still luckily stays present, and we counted back. We went through on the orders in EPIC, at least at UMC, it'll say they got this dose, just this dose. It'll list them, but you would think it would be on the MAR, but it wasn't. So we counted 7 doses. So I said, I'm not giving this. The student said, I'm not giving this. So we talked to the nurse. So we held the dose, and the nurse called the doctor to get an order clarification. So without the trough for vancomycin, what other labs can you check to see if the kidneys are malfunctioning? There's 3 of them specifically I'm looking for.
BUN, creatinine, and GFR.
and creatinine.
And what electrolyte?
Potassium.
Potassium.
Correct. So luckily we had labs. We had a BMP, basic metabolic profile, each day on this patient. And yesterday morning's BMP, the GFR was 100, the creatinine was 1.21, and the BUN was normal, and the K was within range. But I still didn't want to give it because that does not. The definitive thing is to check for the trough. So we held it. I think this patient was in better shape because the patient was young. He was in the early 30s, but yeah, don't be that nurse that kills the kidneys. So, any questions about that? So when you get out and start practicing as an RN, make sure wherever you go to work, find out what the glitches are in the EHR. Know this, that Ochsner uses EPIC and LCMC uses EPIC, but there's different platforms. So a platform and an ease of use thing that LCMC might have paid for, Ochsner may not have. So find these out, identify these glitches so you can provide safe care once you get out, okay? All right, let's talk about rhabdomyolysis a little bit. The Coca-Cola colored urine. Rhabdomyolysis occurs, what types of cells are being broken down that leads to rhabdomyolysis?
Muscle cells.
It's muscle cell breakdown with a release of myoglobin. This is similar to protein molecules because myoglobin molecules are large, just like protein molecules. So when you have this problem, acute tubular necrosis develops, ATN, I spoke about that a little while ago, and the capillaries in the glomeruli become leaky, and they're spilling myoglobin into the urine, okay? And it leads to this Coca-Cola colored urine. So what can you identify? So think of muscle breakdown. Think of some situations that would trigger this from happening. Can anybody identify any?
Extreme muscle use, extreme exercise.
Yep. What else?
Being like bedridden, post-surgery, or like burns.
Yep. Very good. What else?
Seizures.
Seizures, good. Trauma. Think of a couple of extreme exercise types of situations. Think of all the firemen out west who are out there battling the fires. they're in extreme situations. Think of the military. You know, you strap a 40-pound pack on your back, and you go running 20 miles or hiking 20 miles in the middle of August. You know, you're going to have, muscle cell breakdown. Other instances, other causes, patients who overdose on drugs. They don't want to eat. They don't want to hydrate. They just want to do drugs. So this lack of hydration can trigger this. Any other types of temperature extremes, crushed injuries. Think of falls in the elderly. If an elderly person falls and nobody finds them for a couple of days, they wind up having issues with rhabdomyolysis and acute kidney injury. So you may see these elderly come in that have these issues. Let's see. Triathlon, burns, yep, very good. Nola got it all, that's funny. So yeah, any type of overexertion. Gym enthusiasts. So what are you gonna do for this patient? What are you gonna do to treat this patient? Okay, let me start off. What type of acid-base disturbance are they going to come in with?
Metabolic acidosis.
Very good, very good. So then after that, you may get a solitary blood gas. What are you going to do to treat these patients?
Fluids, bicarbonate.
Yep, fluids, IV fluids. You know, you're going to give them boluses. You're going to give them IV push bicarbonate. You're trying to trigger diuresis, all right? You may even need to put the patient on dialysis temporarily. You know, they put a line in, they may have to be dialyzed for a couple days if it's extreme. So what are you going to see in your electrolytes? What's going to say that again?
Increase in potassium.
Potassium's going to be elevated. What kidney markers are going to be doing? What's your BUN and creatinine going to do?
They're gonna be high,
All right. GFR is going to be what?
low,
Yep, very good. All right. Creatinine, BUN, potassium, and phosphorus will be elevated. BUN, creatinine, potassium, and phosphorus will be elevated. So you may see proteinuria and myoglobin in a urinalysis. What's going to be diminished? What electrolytes are going to be diminished?
sodium,
Calcium.
Yep. Calcium. Bicarb's going to be low because they're acidotic. And what else? What other thing do the kidneys manufacture that helps that is deficient in patients with kidney disease?
red blood
Red blood
cells,
cells.
Yes, correct. The production of what is impacted?
Red blood cells.
What's the hormone?
Erythropoietin.
That's why your patients get epoetin post-surgery, post-dialysis. They used to get blood transfusions, but when everybody was coming up with Hep C in the 80s, they went to a manufactured catalyst for producing red blood cells. All right, so you're going to see these elevated labs and diminished labs in acute kidney injury, especially the oliguric phase, and you're going to also see this in chronic kidney disease. All right, so remember these. Remember I said last week, there's one phase in acute kidney injury that's parallel to chronic kidney disease, but as the kidneys come back to life, that resolves, okay? So this patient needs an intervention. Rhabdomyolysis hopefully will be reversed in a few days or a week. All right. Okay, that's not working. That worked. All right. These are the phases. We went over these a little bit last week. What's triggering this acute kidney injury? What's making these kidneys have an issue. That's the initiating onset phase. Then the oliguric phase. So at this phase, what do you think is happening to any fluid that's being taken
Hold.
in the oliguric phase?
It don't respond to the fluid.
Retaining it.
They don't respond to fluids. They're hanging on to fluids. The kidneys aren't function for them to eliminate. What do you think's going on with your urine output?
Decrease.
Decreasing.
Less than 400 cc's a day. All right, so think systemically. You're holding on to all this fluid. What are some assessment findings?
Fluid overload, crackles.
Yep. What else?
Weight.
Weight gain?
Weight.
What else?
Weight gain.
JBD.
JVD? What else? Somebody's listening to rock and roll. What else? They'll have crackles in the lungs. They may be short of breath. If it gets bad enough, it may have frothy edema. Yes, very good. You may even auscultate an S3. An S3 is an extra heart sound that happens when the ventricle has to pump literally twice to expel the fluid. So lub-dub-dub, lub-dub-dub. All right? So this is your oliguric phase. Remember, this is the phase that parallels CKD. All right? And your labs in the oliguric phase, I'm going to repeat it again. What's going to be elevated?
The creatinine and the BUN.
And what else?
Potassium.
Yeah.
Potassium and phosphorus, right? Right.
Yep.
We're going to talk more about phosphorus role a little bit later in CKD. What's going to be diminished?
The calcium.
Calcium. All right. So think of that. Phosphorus and calcium have that inverse relationship. When the phosphorus is high, the body is releasing calcium. What's your source of calcium in the body? Bones, all right? So that elevated phosphorus, the body's trying to create equilibrium. Calcium will leach out of the bones and then be eliminated. So then they'll be hypocalcemic. So remember that relationship. What else is going to be diminished? Sodium, what else?
GFR.
H&H.
Yeah, GFR, we docking. Yes, very, very good, Gabrielle. H&H is going to drop, and your bicarb, because kidneys will produce bicarb. And you may see proteinuria. So then, once the cause of the AKI has happened and been identified and corrected, and they're starting to come out of oliguric phase, the kidneys are coming back from vacation, they go into diuretic phase. So what are you going to see with that?
Increase urine output.
Urine output.
Yes, you may get up to 10 liters a day of urine output. So the intake is going to be much less than the output. Okay, so rapid fluid loss, but remember to keep checking your urine specific gravity because they still may not be able to concentrate urine yet. So with all this rapid fluid loss, what do you think is going to happen with your perfusion?
Hypotension, maybe.
They may become hypotensive. The MAP drops below 70. Check your cardiac output. Okay, you don't want to give a nitroglycerin to this patient because you're gonna bottom them out. And then recovery phase, urine is able to be concentrated again. The kidneys come back to life, and all is well. So, all right. So this is your nursing management. The most common cause of death is infection. your patient, you're going to do an assessment, obtain good history, physical, rule out potential causes, any nephrotoxins, any other chronic disease, comorbidities. Are there kidney stones? Do they have azotemia? Diagnostics may be done, labs, imaging, kidney biopsy. May do a KUB, check in BUN, creatinine, and GFR. Okay. Your nursing management. Sorry, I'm making a note. All right, so drug therapy, but remember not to overburden them. If there's compromised kidney function, you need to monitor that. Good nutrition. So, what kind of nutrition do you think these patients? What kind of diet what do you think these patients will be on?
Low
Low
protein,
protein.
low
Yes.
phosphorus.
Yes, low protein, good carbs, not just, white rice or pasta or bread or all the good comfort food things. Good carbs, veggies, limited protein. What do you think what type of medication is this patient going to get? Remember, they have hyperphosphatemia, so what would you expect this patient to get?
Calcium phosphate.
Which is a phosphate binder, right?
Yes.
Yes. So calcium carbonate, Tums. I think that's what Tums is. That's the cheapo phosphorus binder, but others are Sevlamer. You may see that it's given with meals, so it helps the patient bind phosphorus and eliminate. Phosphorus is ubiquitous. It's in everything. It's in veggies. It's in grains. It's in protein. So monitoring that hyperphosphatemia and giving phosphate binders. All right. Monitoring your INO, CBP, especially when they're in which phase? CBP monitoring, which phase would that be critical? Oliguric, but more so the diuretic. Yeah, because you don't want them to bottom out. They may get fluid boluses if you're trying to flush out any toxins. They may have temporary dialysis, and they need follow-up because you don't want them going back into acute kidney injury. They need excuse me, consultation with a dietitian, monitor daily weights. They may need dialysis temporarily. Good teaching, that's critical. 40 to 60% morbidity and mortality in acute kidney injury. When you have a patient in AKI who has hyperkalemia, what are you going to do? What are you going to do for hyperkalemia? What can you give this patient?
Give glucose, insulin, and gluconate.
Glucose, D50, insulin. You can give them sodium polystyrene, but remember, it's working through the GI tract. It's much slower as opposed to giving D50 glucose or insulin drip, which can work quickly. All right, now let me look through these chat. Normal GFR, Gabrielle, I have a picture of that coming up with CKD. 80 to 100 GFR is normal. I thought we were supposed to go with the lab values off the lab sheet clinical paperwork. What's specifically are you referencing there, Jennifer?
Like all the lab values, like for all the tests, shouldn't they be like the ranges off of the lab sheet that we have to fill out for clinical?
Yes, it should be. Did I misstate one of the labs? Did I misstate one?
Not that I know of.
The lab sheet, you are correct, Jennifer. The lab sheet is based off of the Mosby's Mosby's textbook, the Pagana book on clinical labs. I have know if you guys,
Dr. DeLima, I couldn't find the GFR in that lab book, but
And-
the one on the clinical sheet says above 60 is normal. So that's why I just wanted to clarify.
yes, Gabrielle, and I'm going to talk about that more in the second hour. The goal, what you need to watch these patients for is if the GFR starts dropping below 50, 60 to 50, then, and it stays down consistently, then you know your patient's in CKD and you're progressing towards eventually going on dialysis or getting on a transplant list. We're going to talk about that some more in the second hour. So thank you for the question. School versus reality. Okay, yeah, you're right. You know, learn what you need to know for school. We're somewhat aligned with reality, but when you get out and practice, you want to check what's your lab ranges in your particular facility. All right. Okay. Good. Take a 10-minute break. Come back at 9:25. everybody? So, does anybody have any questions? Somebody say something. It's awful quiet. Hello?
Hello.
Hi.
No questions.
Silence is golden.
No, silence is golden, but it's like I'm talking into the ether.
Oh, we are here. We're listening.
Okay, let's start the last hour. So, we're going to go through chronic kidney disease, which is progressive, irreversible destruction of the nephrons. They're checking out and to disappear forever. So, your trifecta, your diabetes, hypertension, kidney failure is what you're going to see predominantly. Other causes, autoimmune disorders, systemic infections, anything affecting the lower GU tract, UTIs, kidney stones, cancer, family history, and toxin exposure. Your diagnostics, urinalysis, ultrasound, and IV intravenous pyelogram, IVP, intravenous pyelogram. Kidney biopsy. A lot of times these patients will have a kidney biopsy, and kidney biopsy isn't as bad as if you're doing a lung biopsy where you have the potential of a pneumothorax. But kidney biopsy, they're going in through the retroperitoneum, but want to make sure they're not going into the peritoneum itself, because then that could create bigger problems. Complete metabolic profile, CBC. Your treatments, dialysis, drug therapy, nutritional support, and kidney transplants. So the prognosis, some patients are unaffected, others progress to end-stage dialysis and possibly death. So I mentioned last week that patients that are in end-stage kidney disease, they start going to dialysis. They go to these dialysis centers that are there. There's many in the New Orleans area. In addition to inpatient hospital dialysis units, there's freestanding dialysis units. And the industry behemoth is DaVita. And so they are everywhere. So dialysis nursing is a rewarding career. In dialysis nursing, you really get to know your patients, but dialysis nursing is kind of tricky because these patients are very sick, and you may have patients that come in for dialysis that will die during dialysis. So it's a sad type of nursing career to choose, similar to OB. OB, yeah, happy, joy. You have mamas and babies and everybody's well and healthy, but the incidence of mother-baby death is very high in Louisiana. So, you have the good with, unfortunately, the bad sometimes. So dialysis being the same thing. We have a couple chats. Ashley said, am I on mute? No. Ashley said, CKD and end-stage kidney disease are not the same. The progression of the disease goes into chronic kidney disease into end stage. So they are the same. It's just end stage is the end of the line. Okay? All right. Let's get this clicking again. All right, so the role of angiotensin 2, this is your hypertension. This is just a picture. Use systemic and glomerular hypertension, release of cytokines, and then this is when you have your increased protein filtration through the glomeruli, and that's when you start seeing proteinuria, okay? So the hypertension does not do justice to the nephrons, all right? and your role of diabetes, hyperglycemia, they start having albuminuria to frank proteinuria, GFR drops, and then they go to end stage. Progression is like 5 to 10 years. So, okay. The role of chronic kidney disease in cardiovascular morbidity. Patients can develop tachyarrhythmias. They can have sudden cardiac death. They have valve disorders because the skeletal system is releasing all that calcium to compensate for that hyperphosphatemia. They may calcify on the valves. It may be endocarditis from the azotemia. They may have atherosclerosis, systolic, diastolic function, and other types of pericarditis, pericardial effusion. Arrhythmias, coronary artery disease, AFib, all are problems with chronic kidney disease. Okay? All right. So these are your stages. So when you're studying this, your GFR greater than 90, most people walking around with 100 GFR. I think the patient that we had yesterday who we were given the vancomycin, it was the 8th dose, that patient's GFR was 100. So his GFR was working, but we didn't want to make him not work, the kidneys not work. So mild CKD, 60 to 90, moderate, 30 to 60. So when they get into the stage 3 and that's GFR is dropping and stays below 60, that's when the conversation needs to happen for dietary changes, lifestyle changes, possibly even go into dialysis. Severe kidney disease, 15 to 30, end stage, the GFR is less than 15. So these patients have to be on dialysis. All right. Remember, once GFR starts dropping, just like creatinine, you have 50% loss of function in your kidneys. All right. So when you have, I want to mention this, when you have hyperphosphatemia, because remember, phosphorus is in a lot of things in the diet, and your patients develop hypocalcemia, what are some markers of hypocalcemia? And how do you assess for hypocalcemia?
It's travoxine.
Facial twitching.
Vostex is the facial nerve or the hand?
The hand is one of the That's the facial nerve.
The facial nerve.
Vostex is when you have on the facial nerve. Trousseau's is when you put a blood pressure cuff and you see spasms in the hand. When you those are two markers that they're not testable for this, but you may see on boards.
What
right?
about like tingling and paresthesias?
Yes. Other symptoms: muscle cramping, irritability, tetany, twitching, paresthesias, weakness, spasms. So these are symptoms to monitor for. Okay, so we're going to reiterate this. In chronic kidney disease, what markers are going to be elevated? What lab work's going to be elevated?
BUN,
Creatinine,
Potassium.
hyperphosphatemia, and hyperkalemia. What's going to be dropping?
Calcium, sodium, and GFR.
Yes, GFR.
Bicarb.
Who's rocking out? You gotta hit the mute.
It was me. I'm at Starbucks, but I was answering.
Starbucks. Okay. All right. So, any questions about stages? This is dependent on the nephrologist. It's dependent on the patient. GFR is a great thing to trend in your patients. whether it's going up or recovering in acute kidney injury. So these, keep an eye on this if you go into nephrology nursing. All right, so this is in your book, but feel free to take a picture of this. These are the clinical manifestations systemically. All right. Your endocrine system is affected. There's hyperparathyroidism, glucose intolerance. So, what do the parathyroids regulate?
Calcium.
Calcium.
Your calcium levels. Correct. And so, excuse me, when you have hyperphosphatemia, it can impact release of parathyroid hormones. But check this out. When I first started teaching, I was at another hospital. I'm at UMC, I know right now, but I was in another hospital. And we saw a lot of kidney failure at that other hospital. And one time we had a patient who had a thyroidectomy, okay? He had, I guess, I don't know, he had a goiter or something. So what happens in the OR is when they take the thyroid out, sometimes the surgeon doesn't dig out the tiny little parathyroid nodules. And so the parathyroids get thrown into the formaldehyde with the regular thyroid. So this poor patient was so out of whack with his calcium. This patient was taking a dozen Tums a day. He was taking 4 to 6 at each meal. He was taking Tums as his phosphate binder. Tums is calcium carbonate. It's a cheap phosphate binder. You can get it at Sam's or Walmart or Costco for like, $8 for a big bottle of 500. So think of that. I mean, so do your history. If you see a big scar here, oh, by the way, did you have a thyroidectomy? Oh, yeah. So think along the lines of managing this patient. If they don't have parathyroids, you're really going to have to stay on top of the phosphorus calcium continuum. Okay? Respiratory, they can get, because of the azotemia and uremia, they get irritated pleura. They may have pulmonary edema. They're holding on to fluid. Urine, they have nocturia and oliguria, anuria. We've talked about this. They may have hematuria and then proteinuria. GI, oh, not good. They'll have anorexia, nausea, vomiting. They may have gastroenteritis. They may have complications of ulcers. Musculoskeletal, when they're losing all the calcium from the skeletal system, they get painful bones, osteodystrophy, bone pain, and the bones become brittle, and so they'll have spontaneous fractures. So it would behoove to have these patients to have a bone scan, a DEXA scan frequently. Immune system will be compromised. They're increasing susceptibility to infection. Think of the neurological impacts: apathy, lethargy, headache, impaired cognition. They may have gait disturbances, which is neurological and musculoskeletal. Cardiovascular, they're going to have issues: high blood pressure, coronary artery disease. They'll be anemic, impaired clotting too. So they'll get the erythropoietin, the epigen, and you may see them on Neupogen as well. Neupogen helps with, white count and whatnot. Reproductive, they'll have issues, female and male. The skin, pruritus, uremic frost, and then the metabolic processes down here, which we're talking about over and over. All right, so it affects the entire body. It's not good. So your patients are going to get phosphate binders. These are some examples. Do you give these with meals?
Yes.
Calcium carbonate, your Tums. Calcium acetate is Foslo. Look at these. Calcium bind to phosphorus. Okay, makes sense, right? Sevelamer, a lot of times we have Sevelamer at UMC with a lot of these patients. Other binders are lanthanum, aluminum, and aluminum hydroxide. Amphigel, aluminum hydroxide, is also used for stomach upset. It's an older drug. I'm not even sure if they have that on the market anymore. What is your range for phosphorus? What's your phosphorus range? It should be.
3 to 4.5.
Correct. 3.0 to 4.5 milliequivalents per deciliter. That is your normal range for phosphorus. All right. So, can anybody name foods that are high in phosphorus? Yeah, no, we're not dietitians, but what are some examples of foods? I mentioned a few of them earlier.
Green leafy vegetables.
What else?
Beans, nuts, milk.
Yep, dairy, very good. Cheese, soy, seafood, poultry, and pork. All of these, especially your proteins, limiting the protein, it helps both ways. Reducing the nitrogenous waste because you're not intaking as much protein, and reduces the hyperphosphatemia. So these are all important in your dietary teaching, your discharge teaching for these patients. So the other thing that happens with these patients, they're on fluid restrictions, okay? So they'll have decreased urine output, they'll have decreased to none, the oliguria to anuria, rapid bounding pulses, shallow respirations, JVD, increased blood pressure with narrowed pulse pressure, so the difference between systolic and diastolic is reduced. So the goal is to prevent increased cardiac overload, fluid overload, and prevent pulmonary edema. So this comes into play once your patient is at the end stage and they're going on dialysis. The fluid balance is important with these patients with dialysis, and the nephrologist will set a patient at their quote unquote dry weight. And so when they come in to get dialyzed, they're weighed before the dialysis, then they go through hemodialysis, and at the end, the goal is to attain the dry weight. So a common complaint with these patients is their dry weight is too low. And so the problem with this fluid overload too is the systolic blood pressure is going to be high. It's going to be elevated. So think 160, 170, 180, your systolic is high, MAP above 100. But if these patients are on antihypertensives and they go to dialysis, are you going to give these antihypertensives, or are you going to wait till after dialysis?
Wait.
Correct. Now, of course, if your systolic's above 200, you may have to give them some hydralazine IV push or something, or some clonidine PO, because you don't want them to stroke out. I mean, that's the opposite problem that can happen. But if you have a patient with a systolic of 150, 160, and they go to dialysis and they take off 4 to 6 pounds of fluid, which is 2 to 3 liters. Remember, liters and kilograms are equivalent. So 2 to 3 liters is 2 to 3 kilograms. All right? 3 kilograms are pulling off, multiply by 2.2, it's a little over 6 pounds. So you take all that fluid off, you don't want them to bottom out post-dialysis. With me? All right? So working with these patients, they may come in, we got several seasons around New Orleans, and a lot of our customs are based on gatherings around food. Think fried chicken during Mardi Gras. Think crawfish boils over Easter weekend. Think of all the great food Thanksgiving and Christmas. So, these patients are supposed to eat a very restrictive diet, but the temptation is so great. The goal is to try to get everything in moderation. But if they can't attain that, they may have more fluid on them when they come into dialysis after some type of a celebration or a holiday. So you just have to work with these patients and realize that they're human, The really non-compliant ones are the ones that are not even going to show up for dialysis. But, patients who are trying their hardest, you just have to work with them. All right. So we're not going to do group work today, but we are going to talk about the diet. You're limiting foods. What are the 3 foods you're going to limit with these patients? The 3 main types of foods.
Protein.
Protein, yes. What else?
Potassium.
Yes. Potassium, foods high in potassium, and then foods high in phosphorus. They're going to get their phosphate binders. What are some examples of some foods that are high in potassium?
Potatoes.
Okay.
Bananas,
Yellows.
strawberries.
Bananas. What about orange juice? Orange juice is very high in potassium. So, maybe suggest an alternative to orange juice. I know a lot of people like their OJ in the morning. See if they can take apple juice. Potatoes. Oh my gosh, you got the double whammy. You're eating Lay's potato chips. You got the salt and the potassium. Potatoes are very good for high potassium. Let's see. There's a couple of comments in the chat. Let me take a look. So if it's water, meats, they should drink beer. What you mean by that?
Right. So it's a diuretic, right?
It is,
And
but
it also tastes so good.
yeah,
Yeah.
but you can't drink beer because it's fluid. These patients need to be on a fluid restriction, and we're talking drastic. 500 cc's of fluid. This is 500 cc's of fluid a day. That's it. That's not much. Think of that. That's all you're allowed to drink a day. So drinking beer might maybe not be the most conducive to hydrating. Maybe if it's light beer, I don't know. Okay. So let's see. Can you give your patient can your patient take a salt substitute? You try not to give them.
No.
Why?
It's KCl.
High in potassium.
Potassium chloride.
Correct. That's the substitute in salt substitutes, potassium. So you do not want to give them or encourage them to take that. There are a lot of herbs out there, herb mixtures. A good one is Bragg's, Braggs. They have these nice herb mixtures. Paul Prudhomme puts these salt-free, potassium-free herb mixtures. His onion and garlic mixture is really good. So they cannot get a potassium-based salt substitute. Good. One more thing about the diet. When patients start on hemodialysis speeds up the metabolism somewhat. They may have a slight bump in protein intake, okay? Because yes, you have to restrict protein, but you can't eliminate protein because protein plays a role in that albumin, the oncotic pressure. So make sure that they consult with a dietitian to get their caloric needs met. All right?
We usually give 0.6 grams per kilogram of protein for kidney patients.
Okay, where do you work in an outpatient center?
No, I just know that from being a dietitian.
Oh, okay, cool. 0.6 kilogram, 0.6
Grams per kilogram.
grams per kilogram. All right, good to know. Okay. Any questions about nutrition? All right. Let's see. There we go. Okay. Let's talk about what to do when you have a disaster and patients need to be evacuated, especially patients who are in end stage kidney disease on dialysis. This is an actual picture. I worked here. Does anybody know where this is?
Hey, right outside the VA and Charity.
Charity,
Right
chaos.
down that Gravier Street. This is the emergency room entrance to Charity Hospital. I worked there for 15 years when I finished Charity nursing school. Yes, I'm a Charity grad. Yay! And I worked in the OR there in this facility. It was heartbreaking to see this happen after Katrina. So if it wasn't for the Louisiana Department of Wildlife and Fisheries coming in and rescuing people, I think it was day 5 or 6. So you notice these patients are being evacuated. They have their medical records around their neck. You know, back then, electronic health records were not the norm. So these patients were being evacuated. So what do you think can happen for these patients who are in end stage? What do you think the goal is to help them?
Well, you have to balance their electrolytes and fluids.
Right, you have that. You know that the fluid and electrolyte imbalance. What is the goal? What is the best thing these patients need when they're being evacuated?
An appointment with dialysis.
They're going to need dialysis, right? They can't go more than 3 or 4 days. One time we had a patient on our unit at UMC who hadn't been dialyzed in 2 weeks. I really messed up. I said, "Oh my gosh, how are you not dead?" And I'm like, "Oh, wrong thing to say." Boom. But that's the goal. They have to be dialyzed immediately. So the other problem is, what do you think these patients are going to be able to adhere to a regular type of a diet when they're in the evacuation?
Oh,
No, they're probably eating MREs, meals ready to eat. They're very high in sodium, high in protein. You know, it's extremely hard to get a proper diet. So they're going to show up at a dialysis center, say in Alexandria, Shreveport, Jackson, Mississippi, Birmingham, Montgomery, Alabama, and they may need to get dialyzed several days in a row. So these patients who are at end stage, when I was in graduate school, I worked on a unit with a transplant team, and they were managing these patients prior to getting a transplant. And they were telling me when these patients were evacuated, they were calling dialysis centers around the Southeast trying to find places so these patients can evacuate to and get dialysis. The other thing, I don't know if y'all remember, but back then it took a while to figure out the only way to communicate is via text messaging because phone cell towers were down in the 504. So a lot of these nurses who were managing these patients got outside the 504 area code cell phone numbers to help with these patients. So the goal is to get them somewhere they can get dialyzed, help them regain some sort of normalcy in their life. It's what are some other problems that can happen?
infection.
Yes, infection can come up. What about what else?
They may not have all their meds they need.
Yes, very good. They may not have all their meds. This is when stopping at Walmart and getting a bottle of Tums is going to be helpful. What else? They may have cardiac problems, because of all the fluid overload. So, hyperkalemia, somebody mentioned that, the fluid retention. So the priority is to these patients is to get dialyzed. And so these end-stage kidney failure patients are at the top of the list. Your first ones out are your vent-dependent patients. Then your dialysis patients are close behind. All right. Another thing I think we talked about a little bit last week is making sure their benefits are okay. So remember, once a patient goes on dialysis, they're automatic SSI disability. So making sure they've got that paperwork as well. Nowadays, they may get a jump drive or a disc or something like that in order that has their medical records on them. But these are things to remember when you're taking care of these patients. All right. Yeah, it was a sad situation, very sad. It's dystopian nightmare. I hope it never happens again. So, all right. So we're moving on. Any questions about kidney failure, kidney disease? See if there's any chat comments. Nope. All right. So let's talk about dialysis, and this is our last exemplar. And then after this, I have some practice questions for y'all. All right. So dialysis, there's 3 types, but testable is hemodialysis and peritoneal dialysis. All right. Usually initiated when the GFR falls below 15 or 10. When you see those GFRs 7 and 8, then they have to be dialyzed. It's a movement of fluid and particles across the semipermeable membrane. The prognosis is fair. They have to be on a transplant list. That's the best chance for a normal life. They don't have to be dialyzed anymore, but they will have to take immunosuppressants the rest of their life. So the goals of dialysis is restore balance, fluid and electrolyte, acid base, removal of waste, etc. Dialysis can be used for both acute kidney injury and chronic kidney disease. But if it's in a patient with chronic kidney disease and at the end stage, that's going to be permanent. All right. Typically, patients who are on dialysis go 3 days a week, and patients new to hemodialysis will have a Tuesday, Thursday, Saturday schedule. If a patient says they're on a Monday, Wednesday, Friday schedule, they've probably been on dialysis a lot longer, because that's the preferred schedule, Monday, Wednesday, Friday. Unless the patient's working, then maybe Tuesday, Thursday, Saturday works better for them. So what are your indications for hemodialysis? What are the indicators?
You have hyperkalemia and it's not controlled.
Uncontrolled hyperkalemia, yes. This is hyperkalemia that's non-responsive to D50 insulin, sodium polystyrene, yes. What's another indicator?
Heart failure.
Say that again.
Heart failure.
Heart failure, good. Pericarditis. Uncontrolled acid-base imbalance. Mainly, the patient is metabolic acidosis. And, excuse me, patient will go on dialysis to eliminate any drugs or toxins or poisons. That's another indication. Okay?
Sometimes the patient have acute kidney injury. They have like temporary dialysis too.
Yes, correct. So if you have a patient in acute kidney injury, they don't need an arteriovenous fistula. They may just have a line dropped in, a dual lumen or double lumen catheter to go on dialysis for a temporary period. So the length of time is all dependent on the patient, but usually it's, a couple weeks, maybe a month, 2 months, and then that's it. So yes, you are correct. But this patient is going to get better because remember, AKI will resolve, but chronic kidney disease, when the GFR is sustained below 10 to 15, that patient is going to be permanent and you're going to need a permanently placed access. They call it a IV, dialysis access. Okay? All right. So, these patients, this is a schematic. I think this is from your Pearson book. This is, you don't need to memorize this. This is just a schematic of how dialysis works. A patient who is new to dialysis, who's in end-stage kidney disease, will have a arteriovenous fistula, which is a creation of, okay. Can I click the GFR at which the patient should have dialysis? I would say 15 or less. There's not going to be a question on this, but know that your patient is in stage 5. I agree. I don't think Pagana has a GFR either. But you also have to take into consideration the patient who is having systemic problems, who has all those other factors, uncontrolled hyperkalemia, the acid base, uncontrolled acidosis, etc. So yes, that is the marker for that. I'm not going to ask you a question that says, oh, the patient is a 20 GFR, will they be on dialysis? No, it's customized to what the individual patient is exhibiting. So thank you for that, Alicia. A creation of an arteriovenous fistula is done. Usually it's done in the forearm, and it creates an opening between the artery and the vein so that the blood can recirculate. Now, if you looked at the hemodialysis video, that lady who is on dialysis, she's little bitty teeny-tiny. She's very petite, and her AV fistula is so engorged, it's almost like an aneurysm. Because remember, the arterial blood is at a higher pressure, and it will engorge the veins. So yes. So what could be the problem when you have those arteriovenous fistulas that are so enlarged? What's a problem that can happen in there?
Aneurysm.
Clotting.
A hematoma?
Hematoma, yes, because of diminished clotting factors. But yes, development of blood clots. Think AFib. Your left atrium is not functioning, and the blood is pooling in those big old pseudo type aneurysms. So they get blood clots, and so if they develop, say that again.
And infection.
Infection's the other big thing, and infection more so is problematic with peritoneal dialysis. So yes, we are working in the OR. We would get patients in declot AV fistula, and a lot of times that happens when the pressure drops during hemodialysis. They don't have the volume to sustain the pressure, and then the blood starts clotting, and then you can't continue. All right. AV fistulas, once they're created, have to mature. So it may take a couple of months for that fistula to heal and for it to be used for hemodialysis. Okay? Post-dialysis anemia, these patients are going to get erythropoietin to promote production of red blood cells. And another issue with dialysis, especially patients who are new to dialysis, they've been living life with fluid overload for quite some time, but when they start dialysis and they're taking all that volume off, they get issues with IC regulation. It's called dialysis disequilibrium syndrome. Dialysis disequilibrium syndrome. Patients who are new to dialysis, they have IC regulation issues. So what are some things you think the patient will exhibit or will complain of?
Yeah, headache.
Dizziness.
Headache.
Confusion, and the extreme outcome is they develop seizures. So basically what happens is it pull off too much fluid and the brain starts, it could potentially herniate, you know, it's getting to that point where it may be swelling and with the removal of the fluids, it's not actually herniating, but it's mimicking the early stages of that. So what could they do for this patient? What could you do? What could you as the nurse do?
Give them levetiracetam.
Give them what? I'm sorry, I missed that.
It's like to give them Keppra or.
Right, you may need to give them something to prevent the seizures, maybe some acetaminophen. They may have to get a tiny bolus, you know, 250, 500, until they start getting to the point where they can tolerate hemodialysis. So the dialysis disequilibrium occurs patients who are new to dialysis, okay? All right. So this is a picture, this is in your textbook, of peritoneal dialysis, which is done overnight. The most critical complication is infection, right? So these patients have to have meticulous aseptic technique, the connection to the peritoneal catheter. The way this works is this patient looks like she's having it done by gravity, but most patients have a machine. And if you look at that video I posted, the young man is using a machine overnight, so he's able to continue to work in the day. So what happens is these patients have 3 liters of fluid infused into the abdominal cavity, and they go through what's called fluid exchanges. The fluid is exchanged in the machine, and they do a 3 or 4 exchanges overnight. You don't need to know the mechanics of peritoneal dialysis. Just know that it's done through the abdomen, and the problematic complication is infection, because if they get peritonitis, they have to come off of peritoneal dialysis. All right. I also would like you to know how to troubleshoot. So say they have an intake of 2,000 milliliters and the output is only like 600. What's the problem?
To check for kinks in the catheter.
Yep, check for kinks. The patient may need to change position. You know, if they're laying on the side and they're laying on top of the tip of the peritoneal dialysis catheter, they may have to move over to the other side. What else? If they have 2,000 of intake and only 500 or 600 of output, are you going to continue to dialyze them, or what are you going to do? Stop the dialysis.
Yeah, check that site.
Check the site. You're also going to clamp off the intake and until you troubleshoot it to where they can drain out the fluid. If you have an issue that you can't troubleshoot it, then you would call the doctor or the healthcare provider and say, hey, this patient's intake is not matching the output, whatever your numbers are. And these peritoneal dialysis machines will track the intake and output. So call the doctor. They may need to go into the ED if there's a major problem. Because remember, sometimes when these patients are on peritoneal dialysis, they will develop adhesions in the abdomen, which can constrict and impede, the proper function. You need a very motivated family person with family members and support systems. You need someone who has a safe environment to process this peritoneal dialysis, because this is done daily. These patients are subjected to sudden death as well. If you had to troubleshoot an order, I would check for kinks. I would check for position, check for kinks first, and maybe check the position, and then hold the dialysate and call the doctor. Okay? All right. Thank you for that, Nicole. All right, so these are the videos. If you have any trouble opening them, let me know. I'll post them on Canvas. We're not testing on kidney transplant. This is a nice to know. A lot of times these patients are if they have diabetes, they're also transplanted with a portion of the pancreas. They need to follow a strict medication and regimen post-transplant, and take lifelong immunosuppressive drugs, and practice good infection control, because if they're immunosuppressed, then they're more susceptible to infection. The patient will no longer need dialysis, and they will resume a normal life. Okay? So going back to hemodialysis, so when you are disconnecting a patient, you want to check the vital signs at the end of the dialysis run once they achieve their dry weight. You want to disconnect the patient from the dialysis machine. You see here, right where they're connected to the AV fistula, arteriovenous fistula. Assess for bleeding and check for signs and symptoms of infection. Patient may need to have a white count done, see if they're febrile, etc. The other thing for peritoneal dialysis, as you monitor the patient for infection, you want to check the dialysate with the outflow of the fluid, make sure it's not cloudy. You can also take that as a specimen and send that off to the lab if you suspect an infection. All right? All right. Questions?
I have a question.
Yes.
It's more like a situation, but my grandma, she had some kind of kidney procedure performed, and I don't know the exact details, but she ended up getting a stroke from that procedure. She ended up like getting a stroke from that procedure.
Oh my gosh.
So I don't know if you're familiar with like any complications of any type of like kidney procedures that might cause that.
Maybe there was excessive blood loss, or it could have been the anesthesia. You know, maybe she got her vital signs got out of control, her systolic jumped up, you know, or it could be some type of a embolus or something. Did she have a nephrectomy where they took the kidney out, or was it like
I think they were doing like they were injecting the dye into her kidneys.
How is she doing?
She can't remember people's faces, but she doesn't have any physical issues. She just says like that girl or that guy.
Right. Now remember, with neurological complications like stroke and any type of, it can take up to 2 years for the patient to your final outcome of the neurological insult to manifest. So nerves take a long time to heal, you know, neurological function. So I don't know if she had it more recently, but hopefully it will come back in time. You know, if I were you, maybe get her to a neurologist. That's my suggestion, you know, and have a neurologist assess her and see, you know, what they think. Let's see. I have some questions. Take the patient off the machine. Vital signs, that's for hemodialysis. Vital signs, take the patient off the machine, assess the site for bleeding, and check for any other symptoms. Good. That's for hemodialysis. Okay? All right. Thank you for those chats. All right. So we got 5 minutes left. I got some questions. Oh, that didn't work. Let me see. All right. So remember, urolithiasis, we talked, all right. Nurse is planning care for a patient with kidney stones. Which goal is appropriate? Request pain medication at the onset of pain. All right. I'm trying to do multiple things. I'm trying to chat and do this. All right. So this is a patient. Read the question. Let me know what you think the answer is. What acute kidney injury is this?
Is it intrarenal from the tobramycin?
That's correct, intrarenal, because the patient got tobramycin, which is an aminoglycoside, and that has impacted the kidneys, okay? And directly. All right, next one. I know you had another comment in the chat. Just bear with me. I want to go through these real quick, okay? I just have a few more. So, anybody? What's the expected effect of these drugs? D50 and insulin. C is correct. The goal is to try and decrease the potassium. All right. All right, the next one. What's the best indicator of fluid volume?
A.
Daily weights, correct. All right. You would still do the other things, but your daily weights, paints the picture. The scale don't lie, unfortunately. All right, and this is the last one. So we don't ask nursing diagnosis questions anymore, so this is an old one. Anybody?
D.
I was thinking D.
B, maybe.
D is correct because A, you don't want high protein. Yes, low sodium, but you don't want high phosphorus foods. And these patients need good carbohydrates. They need a good source of energy for intake. So a low carb diet what would you replace that with? High protein, and yes, you don't want that with these patients. All right. Let's see. Let me go back to the chat. Okay. Troubleshooting peritoneal dialysis, check for kinks, change positions, clamp tubing to the dialysate, and then call the healthcare provider. Yes. All right. Any other questions?
Dr. DeLima, you said with the AV fistulas, they can develop blood clots. So are these patients also on prophylactic blood thinner?
Yes, they can be, but let me think. I'll have to get back to you on that question. Usually they're not really on blood thinners because when they're on dialysis, the dialysate can have things in the dialysate that can create a blood thinner. So, like for instance, if these patients had an MI, they would be on aspirin, but they won't necessarily be on a blood thinner. I see.
So they're not at the same risk of a PE or a DVT from those blood clots?
Of course they are, but I'm not 100% sure. It's not something I see a lot of anticoagulants with hemodialysis. It's just the problem with the clots forming in the AV fistula is from loss of volume. you know, that's when the clots form. And when they pull too much fluid off, the clots come into play. I don't really see, like, I don't see these patients on warfarin. They may be on Eliquis or something like that if they have some other. So I'm not saying they're not on anticoagulants. They might be, but it just depends on other comorbidities, okay? No to memorizing the GFR ranges. Just know that once it gets below 60, below 50, once they're into stage 3, then they need more intensive treatment and start the discussion about dialysis. Hope I did okay. I hope it was good. I talk a lot, sorry. Any questions, please post on discussion board. I'll be monitoring it. So your test is next week, right? Okay. Thank you very much. Have a good